Afternoon, everyone. I am Himanshi Jain from Eco India, and I'm working as a senior executive in Eco India. Today, we are here for World Family Doctors Day, and in this session we'll have four talks and one panel discussion. And for our session, our moderators are Dr. Nilanjana and Dr. Venkatesh, and director sir will also be joining today's session. So for right now, I'll hand over the mic to Dr. Venkatesh for the further proceedings. Thank you so much for joining the session.
Thank you so much, Himanshi ji. Very good afternoon, everyone. I'm Dr. Venkatesh Karthikeyan, Senior Resident in the Department of Community and Family Medicine, AIIMS Patna. It's a great privilege to be a moderator for this webinar on World Family Doctors Day, organized by the Telemedicine Committee of All India Institute of Medical Sciences, Guwahati. We have received more than 200 registrations, and we expect many to join in the next few minutes. We have excellent speakers from across the country, and we are sure that we are going to have a great academic feast for the next 90 minutes. Without further ado, let us start the session. Before that, Dr. Nilanjana ma'am, can you confirm whether Sarah joined? Okay. I think we can move ahead as planned. Initially, I would like to introduce a very dynamic speaker who actually needs no introduction. He is the Professor of Community and Family Medicine, Head of School of Public Health and Research, and Vice Dean of AIIMS Jodhpur. His area of expertise include implementation research, geriatrics, NCD, tobacco control, vaccines, and global health. He is the chief editor of the prestigious IJCM and has more than 200 publications to his credit. He has H-index of 55 and is included in the world's top 2% most cited scientists. And he has joined us today to talk on the integrated approach of CFM departments, holistic approach for students in learning patient care. It's a great privilege to welcome today's speaker, Dr. Pankaj Bharadwaj. Welcome, sir.
AD sir is there, Venkatesh. I think AD sir has joined. AD sir is there.
Okay. Thank you, sir. To begin with, before going to Pankaj sir's session, I would like to invite our esteemed chief guest and director of AIIMS Guwahati, Professor Dr. Ashok Puranik sir, to kindly deliver the keynote address. Over to you, sir.
Okay, so good morning, everyone. Am I audible now?
Yes, sir. Yeah.
Okay, thank you. Thank you very much for giving me this opportunity to address all of you. It's a World Family Doctors Day, and I think we need to be aware that the things are changing very fast. We need to be technology driven and adapt those newer technology. And of course, treatment is also changing. It is getting more personalized, more specific, and we are having a lot of problems also, aging populations, new kind of non-communicable diseases. So there are a lot of challenges also along with this particular things. And having said that, the doctors, family doctors especially, they are the backbone of the health system. They are the first point of contact for the treatment. And so your doctor has to be really in sync with the presently what's happening around the health industry, where a lot of wearable technologies are there, point of care equipment has come. So we need to upgrade and train accordingly. And of course, it's a kind of teamwork. So everybody has to be taught accordingly about this particular how to effectively deliver the treatment to the communities and to the families. So I'm sure a lot of stalwarts are here who are expert in this particular field, especially special focus on the role of the family doctors. AIIMS is already, a lot of AIIMS have already started courses related to this family medicine, and soon AIIMS Guwahati will be also be the starting that. And in today's time, I really see there is a lack of really skilled manpower. We are lacking, though we have a large population. Doctors do receive a lot of academic qualification, but when it comes to the applicability of those clinical skills and making a real impact is lacking. So this particular area we have to really work on, and I think this resurgence of this particular training and syllabus on family medicine is going to go long way, and we can certainly improve the health of the community. So I congratulate to the people who have taken up this particular topic and organize this particular conference and workshop for on this family health, family doctors day. So kudos to the organizers and the listeners. And I shouldn't be talking more. I think we have experts and we can listen from them. Thank you very much.
Thank you so much, sir, for your valuable words and sharing your time amidst your extremely busy schedule. Thank you so much, sir.
Okay, thank you.
Thank you, sir. Once again, I would like to welcome very dynamic Professor Dr. Pankaj Bharadwaj, sir, to talk on the integrated approach of CFM departments. Over to you, sir.
Thank you so much, Venkatesh. Hope I am audible.
Yes, sir. Yeah.
Okay, great. So thank you. At the outset, I would like to extend my heartfelt thanks to Professor Puranik sir. And I know that you said about dynamicity. I always feel that leaders should be dynamic. And I know Professor Puranik for years together. And thank you so much, sir, for this opportunity and being the part of this interaction or discussion. And thanks to Nilanjana and her team also, Venkatesh and others who have made this talk possible today. So what I will do for the next 7, 8, or 9 minutes, that I will, take you very quickly to, first of all, let me confirm that the things are visible. Venkatesh, everything is visible.
Yes, sir.
Sorry, it is visible, Venkatesh?
It is visible, sir. It is visible.
Yeah, thank you. So what I will do, I will take one case study from AIIMS Jodhpur and then try to, discuss how we integrate holistic approach or integrated approach to these community and family medicine department. And as I work in the geriatric care, so I have taken one example from geriatric care only. So if you look at the integrated approach to patient in community medicine and family medicine, I think the difference lies many a times, even students at our institution, they ask us, what is the difference between community medicine, family medicine teaching, or when we are being taught in general medicine? Because patient is single. So do we have a different approach when we approach these cases in general medicine and when we approach these cases in CMFM? For example, if it is a case of a diabetes mellitus, are we going to do it differently? Then we need to understand, though the patient is single, but the approach definitely is different. In general medicine, a patient is actually approaching to an OPD with a particular complaint, and we call it as chief complaint. So the general medicine practitioner or MD in medicine, they usually talk about that chief complaint only, and then the things are over. But in community and family medicine, as Sir was talking about, that it's more comprehensive, and there more personalized care treatment is to be given. So if we look at the integrated approach, what we call it as integrated, it focuses on comprehensive, preventive, and the most important part is this continuous care, which is very important, and we call it as a continuum of care across all age groups. So when I say holistic perspective, so it just not, address only the clinical symptoms, but we also talk about those social, environmental, psychological factors that impact health. So we need to understand that family physicians, Dr. Raman is here, he's a very close friend. So he will emphasize more on these factors, that family physicians, they talk more on health rather on disease in particular. So the key components of an integrated approach will be preventive care, primary care continuity, community-based intervention. Sir was talking about, Professor Puranik, multidisciplinary collaboration, and that patient-centered model, which is very important. And thanks, Professor Puranik sir, again, when you said use of technology is also very important, because these family physicians have all the records, whether digital or in the book or in the hard copies, when they keep all the records of a family. So what I'll do for the next 5 or 7 odd minutes, I'll take you on a case study. and case studies of screening elderly using ICOPE model. Friends who are there in the call today, what we do here when we have a student of the fourth semester to ninth semester at our place, or maybe postgraduate, we ask them, if suppose there is an elderly who is coming to our OPD, we need to screen him or her through a screening tool. And as we say that there is no fun in reinventing the wheel, there is already a model which is available by WHO, and we call it as integrated care of older people, and we use this ICOPE model. So what we need to understand is that this model starts from the community itself. As the department name is Community Medicine and Family Medicine, we need to understand is that our doctors also need to go to community to screen these people, and who are screened positive in a particular condition, they need to bring to the health facility. So it's a two-way approach. So here, either the elderly person will come to our department, or the second Karthikeyan, Venkatesh, you have raised your hand.
Sir,
Is there an issue?
sir, slide is, are you changing the slides, sir?
Yeah, I'm changing the slides.
Okay, it is
So they are
not.
not changing?
Yes, sir. Yes, sir.
Okay. I'll do it again. Maybe there is some issue. Yes, I will do it. Please see if it is visible
No, sir, not yet.
now.
No, sir, I'm getting a black.
It is visible. It is visible.
Okay.
It is visible. And is
Visible.
it moving? Sir, is it moving? Bhavesh bhai?
Move once again. Yeah, it's
It
moving.
is moving?
Yeah. Now it's better. Okay.
Okay. So that's great. Sorry. So sorry for this technical glitch again. So I was talking about that. Yes. So either the elderly patient need to come to the hospital, or our students or PGs or our doctors need to go to the community to screen them. So we need to understand this ICOPE model. What we generally do is that this ICOPE model works on number one step is to reach to the community to screen on a particular domain, and I'll tell them what these domains are, and then to bring them to the hospital where a customized or personalized plan for the patient is made, and then a kind of a treatment is delivered. So if you ask me what are the 5 steps of ICOPE model, I will say screen for losses in intrinsic capacity. So we need to understand two important, word in the presentation today. One is known as intrinsic capacity, and the other one is known as functional ability. So we need to understand intrinsic capacity means the cells which are there inside me. So they are working, they are getting senile, they are getting maybe their low capacity as we age. So that is known as intrinsic capacity. But with that intrinsic capacity, we deliver some functions that is known as functional ability. We need to understand that. For example, an 80, 75 years person may have intrinsic capacity which is comparable, but the functional ability are different. So we can see even the leadership today. Our honorable prime minister is more than 70 years of age. But if we look at the kind of a functional ability which he has is not comparable with anybody in the world. So we need to understand there is an IC and there is a functional ability. So we screen losses in IC. We make a personal centered assessment care. We make that plan. We ensure that referral pathway, which is the base of a family medicine. So we need to understand when to refer these cases to hospital. And last but not the least, as we say, it's a community medicine, a holistic approach. We need to engage communities and support caregivers. So I'll take one example and then we'll try to understand how do we do it here. Screen for losses in IC. So for ICOPE, there are 1, 2, 3, 4, 5, 6, 7 domains in which we screen our case: cognitive decline, limited mobility, malnutrition, visual, hearing loss, and depressive symptoms. I'll come with one example. So if my student or family physician or PG, they reach to the community, they only ask 3 questions, and they are very common questions. Like, for example, they ask for remember 3 words, orientation in time, place, and person, recall 3 words. And if suppose there is some deficit here, they go for the second step. So the first step would always be ask. So ask in cognitive domain is just to ask 3 questions. For example, if I need to see whether the elderly is having a tendency to fall, we go for a limited mobility check, chair rise test. We request our person to rise up. And 14 seconds, we'll try to see whether in 14 seconds he or she is able to rise in 5 times or less than 5 times. Malnutrition, we call it as vitality. So we try to ask questions. So this, as we say, that history taking is very important. So, but we are not doing depth because we are going into the community. So we ask very limited scientific questions. Only 2 questions: have you experienced a loss of appetite? 3 kg weight loss in last 3 months. And if person says yes, we'll go to the step 2. Visual impairment. So the same thing, which we say, we just try to see if there is any problem in the eyes. We go for hearing loss. We go for a whisper test. Every one of us know how to do whisper test in our physiology classes. So we do that whisper test. We go for a screening audiometry. There are automated app tool which I must say that this must be there in AIIMS Guwahati MBBS curriculum also, where this WHO app-based tool is being used in community, and we try to see whether person is able to hear or not. Or depressive symptoms. That is very important. I think one of the session would be on how actually we are going to go for a depressive symptoms screening in community or in our family medicine clinic. Now, after this step 1, which has already been over, we just screen. And if there is any deficit in the step 1, we go to the step 2. And the step 2 says that we need to go more in depth when we are actually assessing these cases. And we request these elderly cases to come to our family medicine clinic in our urban health training center or rural health training center. So look at this. For example, if somebody is having limited mobility, that chair rise test, the second step would be SPPB. I'll give you an example. If suppose somebody is having malnutrition screening deficit seen, we'll go for MNA determine, which is SNAQ. If somebody, so that we need to understand that every elderly is not going to get deficit in all the domains, but we need to understand that whatever domain is positive in this screening, we need to put a test for that. For example, this first test, for example, that chair rising test was positive. Then we go for SPPB test, and we find, because there is always a tendency of fall in these elderly, and these are balance test, gait speed test, chair rise test that we are going to do in our PHC or CHC or in our hospital. And we see that if there is a positive test, SPPB, then we are going to make a personalized care plan for that elderly. The same thing example which I have quoted earlier is for the cognitive assessment test. For example, we may use any test, mini COG, MOCA test, MMSC, but if there is a positive thing, then we are going to make a plan. Or if there is a need to get him or her connected to a psychologist, clinical psychologist or psychiatrist, we also do that. So this is that generic pathway. Just take a home message that first of all we go for screening, then there is assessment management, which is step 1, which is in the community. If there is positivity in any screening test, then we bring them to the hospital. We go for in-depth assessment of the case, and then we make a personalized care plan. So these are some of the algorithms which we need to understand, and that I think Dr. Raman will also stress upon, that we should always be using that standard treatment guidelines or STGs, or maybe these algorithms which are already been available, and that we give it to our students or PGs, trainees in community and family medicine, what they need to understand. So this is just a snapshot of that. I'll be sharing these slides. Those who want it, they can use it, and I'll be sharing these. So once these are over, I'll go rapidly to this, that how do we do that in Jodhpur. Just wanted to share with that with the audience here, that it was a kind of a pilot project which we started with Canelo, Beijing, and France, which we did in Rajasthan. It was the only hospital in the entire country who used this. So what we did was we tried to find out that through this screening, are we able to screen something positive? You can see there is you can see that in the WHO website also, where you can see that in Rajasthan, the maximum number of people who were screened positive was in the domain of hearing loss, which was in contrast to others. So what we need to understand is, as I was saying, family medicine and community medicine is more personalized care. So if suppose for example, in Canelo, cognitive decline was seen more, or visual impairment was seen more, that may not be in Rajasthan, that may not be maybe in Guwahati. So here what we did was that was 451 geriatric cases, and we tried to even change the the way we are going to assess it. For example, those 3 words which I told you earlier, here in Rajasthan we changed that. We changed it as Khat, Watki, Mungra, but that was something which we did for the screening, and we find that yes, the screening was positive in few cases and we could bring them to our place. Look at this, this is that community engagement or community level work, because there are no chairs in our community in the rural tribal Rajasthan. So we try to find out if there is a 17-inch place where an elderly lady can sit, and then in these 14 seconds, we'll try to find out whether it is positive or not. So this was something which I was talking about, that we try to find out, yes, and in our hospital also. Now we try to find these hearing loss cases or eye problems should come to the hospital, where we can make a more personalized plan to them. Beside that, as I said, it's more about family physician or a community physician. We also tried to take this opportunity for other screening other cases. So this was something which we did, and step 2 screening was also positive. This is the personalized care plan which community and family medicine department made. This is a diary which we give it to elderly every time who is coming to our hospital. We make their personalized plan. This is something which we have written in Hindi. Elderly always feel good and they and valued if we give them something in their hand. So this was printed in our department, and we give it to each and every elderly. So this was just those findings. I'll go to the last slide. And if you look at 441, those elderly who were screened, 103 were being able to refer to the specialist. So we need to understand, community medicine is through community. They are actually taking this to the root of family medicine to the specialist care. So it's something which is required, and as I say, a holistic approach where we are multidisciplinary team is there to support us. Last slide, and let's summarize again. So students need to learn this integrated and holistic approach. As I said, it should not be just symptom based, as every one of us will agree after the end of this discussion today. They need to develop these personalized care plan, but the screening, as I said, the base of the community medicine should start at community, and with the help of family physicians, we should bring them to the specialist care. And I think last but not the least is that through this, we develop that trust on the healthcare practitioners, which these community will have to have that positive attitude towards own health. So last word from my side would be for this World Family Medicine Doctors Day would be a partnership. It's a partnership of patients, treating physicians, primary care, healthcare workers, family, and community to sustain that people's well-being, to ensure that continuum of care. Thank you so much again to the organizers for this opportunity, and over to the organizers for taking this discussion forward.
Thank you so much, sir. As usual, it was a wonderful and insightful session from you, and you made this very engaging by giving your personal experiences and case studies. Thank you so much, sir. So, moving ahead, next we have a very senior person with us today. It's a great privilege that we have Dr. Raman Kumar, sir, as our next speaker to talk on family medicine and its various aspects and avenue. Dr. Raman Kumar, sir, is a senior consultant physician and a family doctor. He's a lead physician and chief of clinical services, Doc 24 Clinics. He has earlier worked in the Department of Medicine in DDU Hospital and in ILBS Delhi. Sir is, of course, the best person to talk on this topic. Welcome, Dr. Raman Kumar, sir.
Thank you, Dr. Venkatesh, and all distinguished colleagues, our friends, and I'm very thankful to AIIMS Guwahati, Dr. Nilanjana, the director here. I can see my colleagues from AII, Dr. Roshni, and other friends, Dr. Bhavesh, Dr. Pankaj, all of you. I'm very grateful to be given this opportunity to talk about family medicine, family physicians on Family Doctors Day. I'm a family doctor, so I'm practicing. Right now I'm in my clinic. I've seen some patients are on waiting. I do private practice full time and the outskirts of Delhi, Noida area. And I cater to high-rise society, IT engineers mostly. And I have a family uh, base of around 30,000 families attached to my practice in this locality. I have 3 clinics. One is Noida Extension, another one is similar localities. It's called Gaur City, and one in Crossing Republic. So, what I want to emphasize upon from the perspective of what is the scope of family practice is that I am working like a health and wellness center, independent, without any government grants. without any loans. I've developed all this sustainability myself from my own skills and competency. One part is, of course, about the clinical part or the patient care part or the community engagement part. And second part is how do you run this business? Because business in the sense of, doing things, the processes of delivering this care in community. So I'm entirely community based. I'm not attached to any hospital. I'm not visiting any hospital. Although I do admit patients when there is a requirement, of course, I keep on getting off and on and off, even myocardial infarction, acute cholecystitis, renal colics, all kind of emergencies and urgent care. But large majority of my patients are outpatient, and the context is different. People often ask how hypertension is different for a MBBS doctor, MD, general medicine, community medicine, family medicine, or internal medicine. So my answer is there is no difference at all. When hypertension comes, is patient-centeredness. Means, it depends on the patient, not on the provider. So we all follow standard treatment guidelines as Dr. Pankaj emphasized, which means the treatment for a particular disease condition depends on the disease entity itself and on the patient, not on the provider. So hypertension, suppose someone comes, just now I saw a patient with 170 by 110 blood pressure, and diagnosis and management of this patient does not differ with the provider, whether it's cardiologist, whether it's family physician, whether it's a community physician, whether it's MBPS or MD, the treatment remains same because that is universal. So there is no difference. Only difference is the context where the patient is presenting. Patient is presenting in my clinic with some other problem. They came with primary preventive health checkup with a report of dyslipidemia, raised cholesterol levels. But as a routine, I check all my patients for their height, weight, blood pressure, BMI. I saw that the blood pressure was high, and I asked, "Do you have hypertension?" She was taking already a antihypertensive medicine. And then I could, suggest her that you have to measure and check your blood pressure regularly. And if it is on the higher side, like what it is now, and then we have to adjust your blood pressure medicine. This is how the contextual thing works, because patient did not came to me for blood pressure hypertension. And this is how the hypertension encounters takes place. So if you ask me what kind of trauma I see, when the trauma comes to your mind, you only think of trauma centers of, Delhi Medical College or AIIMS. But trauma I see in my patients are like, burn patients, crush injury, fall from a scooter, fall from bed, fall in bathroom. And 90% of them will have only cut and lacerated wound, some contusion, some kind of blunt injury, some kind of scratch, cat bite, dog bite, pushed by a cow, something like that. And these kind of traumas are not normally documented in the tertiary care centers. And of course, these patients also require admission. So trauma in primary care, family practice is different. The scope and morbidity profile is different from what it happens at a tertiary care trauma center. So this, goes to the entire range of services that, community may face. Community means, when we say a family physician, we talk about the life cycle care, from antenatal to geriatric end of life care. So it is not family. Family means not family physician in that sense, but it is life cycle care. And whatever in community there is a need for any care, any kind of care, undifferentiated, that comes to me is my scope of work. It is not, my specialization is undifferentiated care. My specialization is multimorbidity. My specialization is all age groups. And this is my specialization because nobody else in the entire health system sees the scope of patients that I see in my patients. And I'm talking about likewise about other family physicians. So this is about scope. So in broadly speaking, I'm talking right now, giving examples from private practice, which is of course, because India is largely a privatized health system, and 80% of the health system is privatized, and 70 to 80% of the outpatient care takes place in the private sector. So I'm giving importance to private sector because a family medicine trained person can run a health and wellness center which can cost crores in the public sector by the government in a medical college setting. You know how it takes for AIIMS to get an attachment with urban health center, and how many staff, how many things required to be done, what is the budget of that. And if that you calculate in my setting, I have no budget at all, and I am profit making. I'm sustainable financially. Profit making means, this is financially sustainable and is supporting my own income and 9 or 10 of my own staff. And I'm also, all my vendors are benefiting who are paying them rental, electricity, and all kind of people, tens of people who are attached to me as vendors. And these all are beneficiary of the system while community is satisfied and is ready to come to me. I see my patients from 9 a.m. to 12 midnight many times because there is a demand. The service I'm giving to the community is global workforce which works for Australian shift, UK shift, US shift, and I have to serve all of them. And my model is digital as well as physical. Physically, I'm sitting in my clinic. Digitally, on my electronic system, my application, I have developed my own electronic medical records where I have record of my recent own records. I have 40,000 prescriptions, 25, 30,000 families are registered in my EMR, and all these patients, many of them, at least 10 to 15,000 people are directly linked in my WhatsApp. So when we talk of the family program of the National Medical Commission, it is about 5 families, whereas in reality we have to see 25,000 families, and they are connected to you on daily basis. It is not one transactional training point of view, but it is a lifelong relationship. When we talk of continuity of care, they come to me once now today for hypertension, tomorrow for trauma, other day for cough cold, then so in this background, I would like to emphasize the overlaps of public health, primary health care, primary care, family medicine, and in the context of universal health coverage. Universal health coverage, which is evolving in our country, 120 million people are covered in the Ayushman Bharat program, and 120 health and wellness centers are functioning in the government sector. And 5 lakh insurance coverage, which is a financial tool, currently is only covering the hospitalizations where you do surgeries and all. It is not covering the outpatient coverage, and it means there is no gatekeeping. There's no gatekeeping to tertiary care. And any country, when you expand your universal health coverage financial tool, the entire 1.5 billion population will not be financially sustainable if you do not have efficient, sustainable gatekeepers, not gatekeepers, but enablers who will screen patients right. It is not about screening and sending to the tertiary care and doing a daily consultation by specialists sitting at the hospital. It is about resolving more and referring less. 90% can be resolved in the community itself by a competent family physician-led primary care team, which we do. So somebody comes to me with hypertension, I don't refer. Somebody comes to me with headache, I don't refer. Somebody comes to me with minor injury, I don't refer. Somebody comes to me with any kind of organ related problems, any organ, I don't refer unless it is myocardial infarction, patient is unconscious and unstable, because I have worked in all high end settings, including Institute of Liver and Biliary Sciences. I've been to intensive care. So what works at tertiary care, I know I have exposure to, and what works in community settings also has a different kind of connotation, which can be learned on a longitudinal learning pathway once you practice only. Because what I am learning, what I am doing cannot be learned in a medical college, hospital, even if you do 20 years of internship, because this setting is entirely different. पीपल से दैट इसमें क्या है, ये तो इंटर्नशिप जैसा है, एमबीबीएस जैसा है, लेकिन आप 20 साल इंटर्नशिप कर लीजिए, यू विल नॉट बी एबल टू डू अ फैमिली फिजिशियन जॉब वेयर आई एम सिटिंग। पीपल कम कि मेरा तो 120/220 और 120 बीपीआ, बताइए क्या करना है, मुझे वैक्सीन लगानी है, मुझे पीवी डिस्चार्ज है, या बैक पेन है, या मेरे कंधे में फ्रोजन शोल्डर है। मैं 3 साल पहले मेरे सर में चोट लगी थी, अभी सर दर्द हो रहा है, अभी मुझे हाइपरटेंशन है, हाइपोथायराइडिज्म है, पैर में स्वेलिंग है, मेरी बाईपास सर्जरी हो चुकी है, और मुझे चला नहीं जाता है, मुझे याद नहीं रहता है। इतने टाइप की प्रॉब्लम जब लेके आएंगे तो आप इंटर्नशिप करके भी आप नहीं कर पाएंगे इसको, क्योंकि इंटर्नशिप इज अ वेरी डिफरेंट बेसिक exposure to clinical care, whereas family practice you have to resolve, you have to treat। आपको ये नहीं बोलना है कि मैं रेफर कर दूंगा और मैं स्क्रीन करूंगा। स्क्रीनिंग इज ओनली अ फ्रैक्शन ऑफ व्हाट यू डू। तो व्हाट स्क्रीनिंग थिंग्स वी हैव हर्ड अबाउट इज ओनली मेंटल कैलकुलेशन। हमारे लिए हम तो टूल यूज भी नहीं करते हैं प्रैक्टिकल में। हम समझते हैं, जानते हैं जेनेटिक टूल्स क्या होते हैं, लेकिन हम उसको वर्ड बाय वर्ड यूज नहीं करते, क्योंकि हम तो विजुअल एक्सप्रेशन से हमारा जो डेटा गैदरिंग, हमारा जो प्रोसेस है, जो हमारा कंसल्टेशन प्रोसेस है, दैट सफाइसेस अस फॉर अस टू बी एबल टू कम डाउन टू द पॉइंट come to the point ki karna kya hai for the patient, so that patient is satisfied, cured, and benefited. So apart from private practice, then of course nowadays Indian Public Health Guidelines 2022 has been revised in that family medicine trained person can be recruited as a specialist. UP government is the first state to recruit. I know 20s of people who have been recruited as specialists. Of course, you can be an academic. Many people will be, of course, as the departments and these programs, CFM departments are there, will be recruited as faculty members, and there are tens and hundreds of them who are working as TNB training sites, MD program sites, and of course you can do research, you can make academics research. Talking about the department of CFM, I have been recently just traveled last week, 2 3 days back. I was in University of Toronto. The department is called Department of Family and Community Medicine, and it is the largest department of family medicine in the world with 2,200 faculty members. I repeated, 2,200 faculty members, 70 training sites, and I do not have slides for today, but it was called Starfield Summit. Barbara Starfield is the renowned figure, celebrated figure of primary care. I'll just take a couple of one more minute, and we must understand what is primary care. Primary care is clinical practice in community setting. Primary health care is a bigger concept. Then public health is a bigger concept. Community medicine has a historical, uh, you know, work tradition or scope of work that we all know about. We have been students of PSN community medicine, which is given much importance in our curriculum, and we have done community work, and we have been to community visits and all. So family medicine, family physician's job in totality is very intellectually stimulating because you see challenge way of talking, and then we are also advocates of the patients. So when I say I'm sitting in private practice, my employer is my patient. So I am also advocate of my patient. I'm also employed by my patients, and my interest is to protect interest of my patients. So my primary interest is to protect my patients because I'm be paid by my patients directly. So I am not working for hospitals for the benefit of hospitals. I'm not working for any pharma company for the benefit of pharma company. I'm not working for government also because then I will run only government program की government ने ये आपको list of drugs दी हैं, ये आपको program दिए, इसको आप deliver करना है. Because my interest is in my community and my patient community, which is following me, which is coming to me, which is paying me to sustain. And it is as clear and transparent as that. If I do any kind of wrong things, malpractice in my practice, people will have means to know what I'm doing, and they will not come to me. If I have to keep afloat, I have to be straightforward, transparent, and do what I'm supposed to do right. So I hope to summarize: family medicine, family physician, family doctors are all same overlapping concepts. Community medicine is, of course, was meant to be for same purpose historically, but there is some slight different trajectory. It is, of course, overlapping with family physician job internationally, and we must understand the overlap and differences of public health, primary health system care, primary care, family medicine, universal health coverage. Why family medicine is being given importance? Because in universal health coverage, where it is public and private insurance, unless there is a community-based strong clinical component, all will come to the tertiary care hospital, which we see overcrowding and over expenditure, over diagnosis at the health system, which is exponentially expensive for anybody, whether it's government or for public out of pocket. So it is very, very important. And all avenues I've already talked about: private specialist in government system, academics, and research opportunities. I have published 200 papers myself. I'm a researcher, I'm an academician, I teach like I'm present here, and I'm also healthcare provider directly. And I'm independent, autonomous professional because I earn my own bread. I don't have to listen to my masters. Thank you very much.
Thank you so much, sir, for such a practical talk. I'm pretty sure that all our participants got inspired by listening to your experiences. Thank you so much, sir. So,
I'll
about
leave because I have my patients waiting, but I will be listening to the discussions. I know renowned faculty members are here, and we will all benefit from their discourse. Thank you.
Thank you, sir. Thank you so much, sir. So, up next, to enlighten us about the role of family medicine in healthcare system, we have another senior person in the field, Dr. Bhavesh Modi, sir. Sir is the professor of Department of Community and Family Medicine, AIIMS Rajkot. He is the chairperson of NTEP Zonal Task Force. He has done MPH and MBA in healthcare from prestigious Johns Hopkins University. Sir has more than 2 decades of experience in teaching, program management, research, and administration. He has more than 90 publications and 10 book chapters to his credit, and he has been involved in more than 30 international and national funded projects. With this short introduction, I would like to welcome Dr. Bhavesh Modi, sir. Welcome, sir.
Thank you, Dr. Venkatesh, entire team of AIIMS Guwahati, and dear colleagues. Can we have the slides loaded after listening academic example-based presentation of Dr. Pankaj and then real-life experience sharing by Dr. Raman Kumar? I will try to have a mix of both. Next, please. So, as the title is Role of Family Medicine in Healthcare System, I will start with what is health system. This is for all of us to understand. Whenever we talk about health system, generally it is thought it is government health system, but it is not like that. Everything that is providing healthcare, including, as Dr. Raman Kumar shared, that he has more than 30,000 families catering to him. There are private multi-specialty hospital. There are NGOs and many other. All of them, all organization, institute, and resources put together, whose primary purpose is to improve health of a population, is a health system. And overall goal of the health system are improving the health status of the population or community, defending against threat to health, like what we have seen in COVID, providing equitable access to people-centered care, and protecting people against the financial consequences. What was happening earlier in India also and across the world, that people are going below poverty line because of the catastrophic care. So these are the overall goals of the health system. Next. Next, please.
Manisha ji, can you please change the slide?
Yes, I think it just got stuck. I'll share again.
Yeah, fine. Share again. So while she's sharing, so once we understand the health system, what is the purpose of health system, then I think fitting a family medicine into it will give a lot of clarity to all of us as a group and how we can leverage on that. Right? Next, please. So another concept talked by earlier speaker was about universal healthcare. So generally what we provide in universal healthcare is what is there in the yellow part. And what is expected under universal coverage is expanding this cubicle from yellow part to the entire red part. And there are 3 dimensions. One dimension is in the same population, you just add number of services. Like the PHC was earlier mostly providing maternal health care along with the communicable disease. Now we have added non-communicable disease into it. So that is one dimension on right side. Another dimension we talk about left side is expand with the same type of services but to the additional population. Like if we talk about urban health, right now a lot of people are there in urban area who have migrated, but they are not part of the healthcare. There is industrialization, urban slums. They are not on part of the denominator. So expanding the same services to additional population. And third is the vertical expansion of expanding same services to the same population, but at a lower cost or making it cost effective. So broader ultimate aim of the health system is to ensure universal health coverage by expanding in all 3 directions. Next, please. Now, interestingly, if we look at the world, it is not fair world. We all know, right? So it is not like that there is no available solution for the health system challenges. But the problem is they are not fairly distributed. For example, if we look at the maternal mortality ratio, it will be in the single digit in European countries, while in neighboring African countries, it will be 200, 300 or 400 per thousand, 1 lakh live birth, right? So it is not like that there is no solution, but it is not fairly distributed. And we have seen that in HIV control program also. ART was available, but it was not available to the African population because of the patent issues and very high cost. And it was available, so people getting HIV in USA or Europe were living, but people getting HIV in Africa were dying. So these are the health system issues. And now, from last few years, it is understood by the government as well as the funder that if we want to solve the problems, we have to come out from the vertical and we have to think problems from the health system viewpoint. And for that, WHO has come out with the interesting framework next, which is known as WHO Health System Building Blocks. Next, please. So this building blocks have these 4 broad purposes which we discussed earlier. Promote common understanding of the health problem, address new challenges and set priorities. Suppose there is epidemic, you need to take care of the epidemic at particular time, but at the same time, you have to ensure your basic health system in place. Third is address question of health system financier. It happens that suppose someone is coming out with new vaccine, that you give this new rubella vaccine or cervical cancer vaccine to everyone. Now, it is fine to expand new vaccine to new people, but not at the cost of your pentavalent or polio vaccination. Right? It was happening earlier that because there is a lot of pressure on pulse polio immunization and monitoring happening, everybody was getting pulse polio and polio vaccination, but diphtheria vaccination reduces, measles vaccination reduces, and that led to outbreak. So that also we need to see that it should not be diverted based on the funder agency goal, but you have to think from the health system view. And last is also make it relevant in current perspective. We have seen what Trump administration way of thinking compared to WHO way of thinking. Right? Next. So this is the basic framework which everyone should keep in mind when we are thinking about family medicine fitting in this framework of WHO. It has basically 6 building blocks or health system building blocks which are on left side. First is a service delivery. Second is a health workforce. Third is the information system. 4 is access to essential medicine or vaccine. 5th is financing. 6th is the leadership and convergence. And when all these 6 different blocks come together, the ultimate purpose is improve access, improve coverage by ensuring quality and safety. That should lead to overall improvement in the health indicators of the population, the health system which is responsive to the need of the population, also ensuring social and financial risk protection like financial catastrophic, and improved efficiency. So in this framework, if we look at this, right now what is happening in the health system is we are producing a lot of doctors. Most of them want to become specialists and super specialists. As Dr. Raman Kumar has shared, when you are a family physician, you will get a patient, will come as a family. You will have an antenatal mother, father is diabetic, and there is a small child who need vaccine. So you need to know all 3 of them. People cannot afford to go to a cardiologist for hypertension and vaccination, to a pediatrician, and then for antenatal the gynecologist. And though those who are able to afford can go, but 80% population is not able to do that. That's what this family physician can be a good fit to improve the overall health system and help us to achieve this desired goal of a health system. Next. And only if we talk about the human resource part, that is one of the building block, we know that producing a medical doctor or a health system research is labor intensive. It is not like producing the BA, BCom qualified people. It requires very experienced team and setup. Also, not only the quantity is important, but the fair distribution. Like if we look at the number of doctors in urban, rural, it's a contrast compared to the population, right? Same way, all other workforce. Also, the competent, responsive, and productive manpower, not those who are working like a typical government, like in my state, or I see in majority of places now government is more accountable, more responsive, but we need to have more user friendly and acceptable by people. And also, not only the salary, but how can we make it a more productive and respectable job where people are feeling motivated to work as a family physician? And I have seen some of my colleagues or senior who are working as a family physician, they have got highest number of respect. The patient will tell them, sir, you tell us the cardiologist or neurophysician, we will go there only. We have no preference. Whatever you say, we will. So they are able to create that respect and trust with the community, right? And also there is need, like recently we had a national conference of family physician in Vadodara, and there was a need that now we are getting a lot of patient of mental health issues, but we are not trained into that. So how we can do a regular training or capacity building of this pool, right? So again, the previous slide we saw of the health system building blocks, we will see that again in the next slide in a very different way, next in a more organized way. Next, please. So again, if we, the same WHO building blocks are reorganized with reference to family medicine. And if you look at this left side, lower 6 points, health workforce using technology or health information system along with the available medical products, supported by financial incentive and good leadership and governance, can lead to a much better health system, which is providing accessible, convergent, efficient, equitable, quality, safe, and sustainable health care that is responsive, ensuring risk protection, and improve population health. That is what is needed by community and patient, not the highly fragmented, very costly, non-responding health system, but we need a robust, resilient, responsive, and cost-effective healthcare through a pool of family medicine physicians who are aware about the family practices, cultural and social acceptable norms, and they can provide advice or inputs which are very trustworthy based on the local situation and holistically as a family, not organ related issues, right? So I'm sure with this inputs of family medicine physician who are, I'm happy to know that UP government has started posting them as specialists. AIIMS has also created post of them as academician, but also maybe CHC level, like the surgeon or gynecologist are getting as a class 1 posting immediately after passing out. Same way, family physician can be posted there. There is huge need in the private sector also, with a lot of flexibility and financial incentive also, even in rural area also. Yesterday, I just saw a Netflix series on Gram Chikitsalay. I would encourage you to see. There is a gold medalist from the renowned college who is not able to connect with the rural population. So not a single patient coming to his clinic, while a local Jula doctor who is part of the community and able to read their mind and eat and sit with them are having queue of the patient waiting outside, right? So I'm sure this family physician who are better equipped with the communication skill and technically enhance what we call high quality specialist, generalist specialist is the need of the hour, and I'm looking forward to more productive inputs by family medicine, especially in the health system. Thank you.
Thanks a lot, sir. It was a great boon for us to hear from senior professors like you who has vast knowledge and experience in the health system. Thank you so much for your valuable time, sir. For the next session, we have our speaker, Dr. Santosh Kumar, sir. Sir is an additional professor in the Department of Community and Family Medicine, AIIMS Rishikesh. He has expertise in family medicine, lifestyle medicine, and mental health. Sir is also an expert in qualitative research and community-based research. I have seen many novel initiatives taken by Sir in family medicine in the community level, and being a dynamic leader, he is the apt person to talk on the topic public health skills and leadership in family medicine. Welcome, Dr. Santosh Kumar, sir. Dr. Santosh Kumar, sir, kindly unmute yourself, sir. Sir, you're on mute.
Yes, sir. My presentation, is it visible?
Yes, sir, it's visible, sir. Yes, sir.
Am I audible?
Yes, sir, you're audible, sir.
Well, thank you very much, Dr. Nilanjana, AIIMS Guwahati, all respectable dignitaries, Professor Pankaj, Dr. Bhavesh Modi sir, and Dr. Raman, all other dignitaries. Thank you very much, first of all, for having me on this most required show on the most important day, World Family Doctors Day. So I have been allotted one topic, that the public health skill and leadership and family medicine. So I was having the words from all the experts, the very senior and eminent academician, practitioner of our country. So what we are destined for, where we are destined and where we have to create leadership. That's the question. Is the family medicine is all about we all are fighting for, or something to strengthen the public health in India we are fighting for? We need to understand that. I quote Dr. Raman whenever we have a conversation with each other. So our each and every effort is to make a way and strengthen the public health system of India. So family medicine is one of the way and one of the skill to reach to in a larger sea, to see, to assess, and to have a larger picture of the public health. So when we talk about the skills, what we need a communication skills, clinical skills, cultural competency, community engagement, preventive care, data, statistics, advocacy, how to have a skill of intersectoral coordinations, that all skills we need in the public health. So what I have mentioned, that we have the public health at one side and the primary care on the other side. We have a primary care setup and we have a public health. We both, but the family medicine is going to bridge both of them. You must be understanding why I have put this slide over here. We have a little bit haphazard pictures of the public health in India. And we have, again, if you see that the hazy picture of primary care as well. So we have to strengthen both. And to get a clear picture that the integration of the primary care and public health is very much important. Because if we are not doing anything about, if we are not talking about the primary care, that is the basic unit of the public health, ladies and gentlemen. So if we have to talk about the public health, we have to have a concept of primary care. Ladies and gentlemen, the family medicine is going to be a connecting link between both. Why and how we can link the primary care with the public health to have a larger picture, and better to say, the larger, successful, efficient picture of public health in country. I think that we are going to discuss today. The strengthening multidisciplinary team. So what we have to do, we have to have interaction with a community stakeholder to strengthen the primary care. If you're talking about the primary care, we have a very limited setup established in the primary care area. We have, if you can see, we can assess the PSC. We can see the situation of the PSC, CSC right now, though the government has done the fantastic measures. The government has done a very, very wonderful initiative in the form of, if you say the National Health Program 2017, National Health Policy 2017, we have given a new initiative, a new dimension to the primary healthcare in the form of UPSC, Health and Wellness Centers, or what we rightly we are saying that the Ayushman Arogya Mandir arm. So that again we need to strengthen them. We need to strengthen them. We have to make the change, and we have to transform the primary healthcare level up to the visible entity. That's why we have to create a multidisciplinary team. We have the multidisciplinary team in the form of CHO, ASHA, Anganwadi, but are they sufficient? No, we have to strengthen, we have to create another team of the stakeholder with the multidisciplinary team. Community engagement and advocacy. We have to make them, because in today's scenario, everyone is talking about the tertiary care. All right. If somebody is having a cough, but Dr. Pankaj has also mentioned about there. So if somebody is having, some of the patient is having the headache, he or she is willing to visit to any super specialist rather than the physicians. Nobody want to consult a primary care physician. Why? Why? Is it a gross negligence at the part of patient, or the gross negligence at the part of fraternity? Where is the gap, ladies and gentlemen? That's why it's a urgent need to fill the gap. So how the people will migrate, mobilize for the primary care physician? They do understand that the headache, cough, fever, there's the minor elements can be treated and well tackled by the primary care physician. Why? It is a increasing or rising need of the super specialty among the public. So how to engage the community? Community engagement means they have to engage. They have to have advocacy for the primary care. They have to create awareness that what the primary care is and how the primary care and primary physician, family physician can help them out of the way, which even cannot be dealt by the super specialist. Then we have to initiate. We have to take the initiative. We have initiated. All the effort is being taken by the AIIMS Rishikesh over here. That the primary care training, research for the public health action. We have recently initiated the primary care research and primary care training for the Char Dham pilgrimage. We are in the process of training even the volunteers for the Char Dham, the basic medical first aid training to them. That is how the people will able to understand, yes, the primary care is important. The basic elements, how to manage how to tackle with elements, because we have a discussion with at the ministry level when we are initiating the Char Dham Yatra. So we do not need the cardiologist over there in the Kedarnath and Badrinath. We need a primary care physician who can tackle, because we cannot open a multi-specialty hospital over at the Char Dham place. Still we need what we need. We need a primary care physician over there. We have to train the primary care physician over there for that particular, so that he can tackle the more than 80% diseases over there, and rest of the diseases can be transferred and referred at time to the tertiary care institution. Promotive and preventive measure. So we have initiated that the Yuva Jos, we are mobilizing youth for the physical, mental, social, and spiritual well-being. So that type of promotive and preventive activities has to be taken care. That is a skill of the family physician. That should be the skill. That is the required skill needed for a young, dynamic primary care physician, so that we could mobilize the community as well. We could make them understand what is the role. We have given a new life to more than 5,000 students over here. We have a good connection with the universities and the schools. So whenever they are having any problem, they are concerned, the youths are coming to us. That is the beauty of the primary care physicians. These are the skills for the primary care physicians. Mass mobilization and advocacy for the family medicines. Why? The family medicine is going to fill the void. Surely, we are here to connect the people. We are here to connect the individual, family, community. But if you are saying, if you are discussing, if you are arguing or having a conversation with each other, it is not going to fulfill. We have to jump into the community. We have to discuss with the people. We have to have a conversation, a dialogue with the community leaders. Here, you can see that Dr. Raman and me, during our FMPC 2024, have a well-known spiritual guru of the Rishikesh. And he has given a definition of family medicine, a new definition of family medicine, and among the thousands of people over there, that no medicine without family. For the first time, we are very much influenced when a spiritual guru is talking, the family medicine is very important. He doesn't have a DNB degree. He doesn't have an MD degree. But he's saying, yes, we need to connect the family if you want to get rid of any of the diseases. That's advocacy, ladies and gentlemen, we have to go with. Administrative mobilizations. During our conference, what we have done, we took all the leaders of the primary care. You can see the Director General Health Services, Mission Director, National Health Mission. We brought them under one roof. We have convinced that we need a primary care. We have to strengthen the primary care. The primary care is very much important for each and everyone. If we want to transform the healthcare delivery system, again, we need to create the primary care system to be strengthened. Here we can send the chief medical officer. We have been having tracks on how to strengthen the primary care, how we can help them, how to create a leadership to help the medical officer of the state. The political advocacy for the primary care and family medicines. We have Honorable Governor. We have the Cabinet Minister for Jal Shakti. So these leaders, when they come forward, and who will tell them? Who will tell them what is primary care? Because we are the expert. We are the expert. Again, quote Dr. Raman in this regard. Then he says that who will tell the ministry that what should be done, what should not be done? Because we are expert now. We are expert. Then we have to convince them. So that we need to have a skill of convincing people. Ladies and gentlemen, that the outcome, what was the public health action after this so many effort, that I'm very happy to know that the family medicine, the first time in the history of Uttarakhand public health system, the family medicine specialist branch has advertised by the NHM. The second is the MD family medicine has been initiated in AIIMS Rishikesh after that effort. So when you are in the hospital, you need to have a wider vision. You are supposed to see the apple. You are not supposed to see the fragment of apple for the public health. If you want to mingle with the public health, you have to see the wider picture, right? You have to see all the dimension of the community. You have to see the dimension of individual as well as community, because ultimately our effort is going to create a new policy, right? If you are not able to create and we are not able to give any knock on the policy making system, that we are nowhere. So that we need to understand what is the supply and what is the demand. That's why I say that for the wider vision, we have to assess the community need, the public need, what they are demanding, what we are supplying. The Viksit Bharat, our Honorable Prime Minister has mentioned many times that we are striving for the Viksit Bharat, primary Viksit Bharat 2047. What as a medical fraternity, what we say that the Viksit Bharat will be possible because of the Viksit primary care 2047. So ladies and gentlemen, we need to develop a Viksit primary care first of all. So developed India, the developed healthcare, and that will lead to the developed primary care. So acceptance of primary care physician, or acceptance of the concept of family medicine and primary care in the public health organization system, that will be the great victory. Probably we can say that we are going towards the Viksit Bharat 2047. None of the country can be Viksit until their citizens are ill. That the primary care is one of the major steps to make the people healthy, sound, and productive. The most of the Indian city patients rely on the tertiary care. What I have mentioned, they are believing on the tertiary care. They are going for a minor element to the super specialist because there is no primary care at all. We are not going to the primary care. Primary care is no more the temptation. Why? Because we are not understanding that. Unless we have a temptation for a particular things, how we can come to know about that? We need to make even the medical students the temptation of primary care. So the cost of providing specialty care for outweigh the cost of primary care. Everything is understood. Still, the temptation is being poor because we are least talking about the primary care at the tertiary care stage, primary care stage, and everywhere. We do understand that only 2% of the desired people who are willing to seek the care, they are going to the tertiary care system. Rest the 28% of them, they are attending the primary care physician. That is the silent primary care. This is not at all the aim. I'm not happy with this picture, right? This is the Arogya Ayushman Mandir. There should be a crowd at the mandir, but there is no crowd. शांत बैठा हुआ है, ये नहीं चलेगा. We do not want peace at this place, right? But what is disruption, destruction, public health, where there should be peace. In the tertiary care place, where the surgeon, super specialists need to be concentrate over the particular diagnosis, there is so huge rush, and because of this distorted systems, there is a poor doctor-patient relationship, and these all news you are getting over there. So that's the common public health fallacy. You know what is that? The system-based fallacy. The system-based fallacy. You know what? Still, we think with that public health fallacies need to be resurgence and remodeling. What is the system-based fallacy? You know that the primary care. Why the primary care is not being given so important as it is being given to the tertiary care system, right? Why the primary care policy has given so much important? Why the primary care policy has given so thrust? So we are asking for that. We are asking for that. Still, we are not 100% in the immunization. We do understand public health is a slow process, but how? In spite of that, we are fighting. Right? For tuberculosis, for the tuberculosis RNTCP, still we are striving. For last many decades, from Pandit Jawaharlal Nehru to this time, because if the primary care policy would have been robust, probably would have been eliminated this tuberculosis a long back. Community-based fallacies. The community-based fallacies means the concept of community demand, community acceptance, a community supply is poorly given attention. The individual concern, if the system and community both level will not be able to accept that what is the primary care, what is their need and supply, so individual will automatically become victimized with these all type of fallacy. That's why the individual is directly going to the tertiary care. Right? Then the AIIMS like institute, still you will get the 30 to 40% of the patient who belongs to the primary care. They don't know where to go. That is why the overburden of the hospital due to underutilization of the primary care. Because of this, we do not have limited infrastructure at primary care. Nahi hai hamare paas infrastructure. Right? Inadequate funds. Funds are very limited to the primary care. Misinformation, low health literacy, cultural barriers, fragmented system. These are responsible for these all. So what to do? We have to create how to make a rapport building with them, how to make, this is my model, what I have created to have experience to implementation, to create a rapport building with them. This is the way we have to mingle with the community. We have to have these, none of them is a medical person in this. We can have interaction, we can address the stakeholder as well. What we have, just we are going outside, we are understanding the pain of the people outside. And we are visiting to the community, we can understand. Now we have intersectoral coordination. So, ministry. Yes, madam, I'll take only 2 minutes.
Thank you, sir.
Well, so this is the tribal ministry. We have a collaborations with them. So we are again trying to coordinate with the tribal ministry and having a tribal family medicine with them, because tribal health is also a primary care. So you can see that what Professor Modi has mentioned, that health system is strengthening with the tribal health. Let's start from a corner and at the policy level. So that's something we are having the submerged phenomena of primary care. Then everything is submerged, and we have to wake up. We have to come up. So that's, we know that we have created 7+1 model. If you're talking about the leadership, we have to go. We have to mingle with the community. We have to think about the stakeholder from that area. That the 7+ program has came out, and this program has taken, it is adopted by the government of Uttarakhand. We can see that one of the leadership right now, and it is running over there, and it is well being appreciated by this. And second model is integrated community health service model, and this model is how to strengthen the community. And this model, the tribal ministry is trying to re-implement this model again. So this, on the basis of this model, we have a book which have been inaugurated by Honorable Governor. So this book is available in Flipkart and in Amazon. You can see that the integrated community health service model. So this is the family medicine of OPD. 2013, we have seen more than 10,000 patients over there. This is again the collaboration and the political mobilization. What we have done, this is again, we have the doorstep primary healthcare model. So we have this model. We are encroaching, transecting the community and giving the doorstep care over there. And this is the participative learning for the actions. And we are working in the different community model, and where the community wellness model, because we're talking of the wellness, that we have to take care about their physical, social, and spiritual wellness in the community. So that's why how we are doing the work. We are trying to advocate the need of primary care. I hope the listener and any students must be listening. They have a good scope to go and create and have to develop the leadership in the primary care. Thank you very much, ladies and gentlemen, for patience here.
Thank you, sir. Thank you so much, sir. It's great to learn from your vast experiences, especially about the way you do advocacy and engage the various stakeholders. Thank you so much, sir. So next, we have the most expected panel discussion on this World Family Physicians Day. The theme for this year is building mental resilience in changing world. For this, we have three expert panelists with us. Let me introduce all the three panelists first, followed by the panel discussion. Firstly, we have Dr. Sanjeev Kumar sir, Professor of Department of Community and Family Medicine, AIIMS Bhopal. Sir is the nodal officer for the MD Family Medicine program at AIIMS Bhopal. He is the coordinator for the family medicine postings of MBBS students. Sir has been developing a 18 days clinical posting module for MBBS students, and he has put it into practice since 2016. Sir has been trained in family medicine from CMC Vellore and has completed 9 funded projects as principal investigator and 14 funded projects as co-PI. Welcome, Dr. Sanjeev, sir. Secondly, it is my privilege to welcome my senior, Dr. Bijit Biswas, sir. Sir is currently an assistant professor in the Department of Community and Family Medicine, AIIMS Diogar. Sir is the faculty in charge of USTC Kalyanpur. He has more than 72 publications with around 3,500 citations and a H index of 18. Sir has worked in more than 10 national and international level projects and is in editorial board of various journals like PLOS ONE, BMC, etc. Sir's area of expertise include vector-borne diseases, school health, occupational health, and chronic disease epidemiology. We are glad to have you with us, sir. Welcome, sir. Thirdly, it's my privilege to welcome Dr. Roshni Jan Ganguly, ma'am. Ma'am is a passionate family physician and is the founder and chief family physician at Ashwin's Care Clinics. Ma'am is the founder and chairperson of the Project Setu Foundation, which works to promote health equity and community empowerment. Ma'am is a clinician, teacher, entrepreneur, researcher, social advocate, and a multifaceted leader. Ma'am also serves as a chair of continuous professional development at AFPI and is active in both Wonka South Asia and Wonka Rural South Asia. With this brief introduction, I would like to welcome Dr. Roshni Jan. Welcome, ma'am. Now, I request Dr. Nilanjana, ma'am, to kindly take over the session.
Thank you so much. So after the discussions we had, now I will just straight away go to the questions, which is the essence of we did this program. So first question will be to Sanjeev sir. I will be liking to ask you the question. In your view, how can we better integrate the concepts of mental resilience and psychosocial care into the undergraduate CFM curriculum?
Thank you, ma'am. First of all, the gratitude for having me here as one of the panelists. So, straightway going to your question, what we have seen and what we have listened to since I think last 1.5 hours, we have covered a lot of ideas and concepts which should be done in community medicine and family medicine curriculum. So, I'll assume that we are talking about MD family medicine and MBBS curriculum for family medicine. I'm not going to dwell much upon the community medicine part. So we all know under NMC we have this ATCO module. The ATCO module, what my understanding is right now quite unstructured, and I have seen specialists from far off departments like even FMT and people from orthopedics trying to teach the skills in attitude, communication, and all. And we all understand mental health and psychosocial care needs a lot of skills and knowledge in communication. So that EdCom module, in my opinion, needs to be restructured or maybe structured in a modular form. NMC and even at AIMS, like in our AIMS, we have, I think last 3 years, our director has introduced the NMC curriculum for the MBBS students here also. And I guess the same might be true for many other AIMS also. AIMS usually doesn't come under the purview of NMC, but still many of the AIMS have chosen to do that. So that needs to be really restructured. One way can be we can have some medical education technology be implemented, like have a flipped classroom, give the structured content to the students, and then discuss on a problem solving approach, maybe a case-based approach, and that can be the knowledge part. Then in the skill part, we can uh, have integrated teaching sessions, like we did it few years back for fever or mostly for infectious diseases, where specialties of community medicine, microbiology, medicine, even sometimes pharmacology, of course, they were there. So these departments can get integrated. They are usually getting integrated for physical diseases departments, not more for the psychiatry or mental health related department. This integrated teaching session, I guess, can be a good thing. There you can have integration of one specialty talks about epidemiology, another one talks about the management part, the third one talks about the public health, or simply the management at a larger population level. One specialty talks about the scenarios in their specific topics, like say, for example, medicine. People can talk about the need for psychosocial or care and mental resilience. In chronic diseases, the surgical specialty can talk about the post-surgical care in terms of these things. Even OBG we can talk about in some specific vulnerable population groups like infertile patients and infertile couples and all. So that can be one. I can also think about the early clinical exposure, where during early clinical exposure, the students should initially be introduced to illness stories. We did that for our family medicine curriculum here. So in the first week, they were not supposed to talk about the clinical part. Just talk to the patient, get the illness story. Without that, what I call as the investigative doctor, the doctor which is like a police person. The way we are teaching history taking is like investigation. The way people, police is doing the investigation, leave that for some time. Maybe in the third or fourth year, we can do that. Initially, just talk to the patient, just get the story, write the story, listen to it. We have audios, we have taken permission from the patients, and we used to discuss those audios. What you need to understand from this sentence what the patient or the relative is talking about. So that we did. During community medicine posting, I guess most of the medical colleges has something called a CPSCR. If the colleges, those who do not have this, the clinical psychosocial case reviews, there is a lot of emphasis on psychosocial. So in the uh, training part, I guess in the curriculum part, these things, this is my view, can really. Thank you.
Thank you, sir, for the crisp yet very clear understanding. So now I will ask ma'am, Roshni ma'am. So what is the scope of family medicine? Actually, you are like the main stalwarts of these areas, domains. So what is the scope of family medicine globally, and how can, like newcomers, or like here now our UGs are all CFM, PGs also. So what is the scope of expanding career prospects? Any training abroad, like sir said he was in Canada, so there were so many faculties there. So we just don't. It's still a gray zone for us. If you can just please highlight.
So thank you, Dr. Nilanjana, and thank you to the stalwarts who are present in the panel and the speakers. I'm truly grateful that for having me here in this session. Now, having continued from where Dr. Sanjeev, has started, and Dr. Raman has emphasized, uh, there are certain keywords which are very, very close to my heart and very, very close to family medicine as such. So, patient-centeredness, holistic care, comprehensive care, coming from a context. What are the ideas? What are the concerns of the patient? And here I would like to highlight really that, we've heard a lot of discussion, and the consultation skills in general, just differentiating that how that is different from any other doctor and to the doctor who's practicing family medicine. It's about the communication skills. It's about how you listen, how you build rapport with the patient, and the particular style of consultation. And re-emphasizing that, the consultation styles, you can read up maybe Roger Neighbor's consultation or Calgary Cambridge model, which helps us anyway to connect with the patient and thereby building mental resilience. I'm giving a bit of an introduction. The reason being, I will move on to what are the courses available. But this is the main factor that helps you connect with the patient. And when you connect with the patient is satisfied, you are satisfied. So giving time, listening, building a rapport, treatment guidelines would always remain the same. Okay, that goes across specialities. But it is the art of the consultation that varies. Now, coming to your particular question, Dr. Nilanjana, is what are the courses available? Now, as we know, in India, we have the MD, DNB, and we have many other courses also, like the PGDFM or the MEd in CMC Vellore and the Diploma in Family Medicine, etc. But I would like to bring a perspective here regarding the courses of abroad. The reason being that courses like MRCGP, whether UK or Australia or the international wing, it usually teaches us how to navigate through this uncertainty. It helps us to navigate through the undifferentiated patient that comes to us. It helps us to understand that what are the consultation styles we should practice in order to complete the biopsychosocial model of practice, which encompasses the mental health or mental health awareness that we are celebrating today in terms of the Family Doctor Day theme. And here in the MRCGP International or the UK or the Australia branch, I would say that they have a particular applied knowledge test where there are clinical scenarios which you have to link with your knowledge and your practical skills. So it's not about just mugging up, diseases. It's not about just dealing with the problems. It is about the patient, or it is about the person who's having this particular problem. So I would like to stress on that. Now, there are, especially coming to mental health courses, there are, courses from WHO, there are courses from NIMHANS in Bangalore and various other institutes. And if we divide it into the subspecialties, like, for example, or interests, like the mental health particularly would come with substance abuse, addiction problems, it comes with psychiatric problems, it comes with simply, what are the day-to-day issues the patient or the person is dealing with when he or she has a multiple problem list or a multi-morbidity condition. Right. So this is what I wanted to say. Thank you very much.
Thank you so much. Now I'll come to Dr. Bijit Biswas. He is our community medicine specialist and a family medicine specialist. I had a scope of meeting him this time in conference also. So thank you, sir, for being here. So now, how can the clinical practice with family medicine be adapted to better identify and manage early signs of psychological distress in everyday consultations, and also the strategies we can apply in low resource settings?
Thank you, ma'am, and thank you for inviting me to sharing the stage with such stalwarts in the family medicine. So, being an epidemiologist by profession, firstly, then converted to family medicine, I will first like to share some statistics that what's the importance of this year's theme of building mental resilience in changing world. That over 10% there are the prevalence of depression and anxiety, which are the common mental health illnesses, but we can care in the primary care, is 10%. Over 12 million people, Indians, are suffering from that illness that can be easily managed, especially at the mild and moderate level at the primary care. And every year, 1 lakh people does suicidal attempts, more in women and more successful attempts in men. But the statistics what I had is that 38% of them might have visited any OPD within 1 week, 64% within a month, and 95% within a year. That means we have missed the opportunity of screening this patient that he might have suicidal ideation, might have felt low, depressed, worthlessness. So this is the opportunity what we should not miss. And I know in the primary care level, there are, especially the government facilities, there are too much patients. It's very difficult to screen each and every patient for mental illness. But at least we can look for the appearance and we take the history. So, but the articulation of voice, the relevance of the talk, orientation with time, place, person. As Raman sir already said that he doesn't use any screeners, but even used by psychiatrists to screen different mental illnesses. So with experience, so at the level of Raman sir, it will be difficult for us, but at the novice level, we can start with certain common screeners like General Anxiety Depression Scale, PHQ-9, Edinburgh Postpartum Depression Scale. This may be applied to the appropriate population. But what I use in my setting is the PHQ-4, which tell us about the overall psychological well-being of the patient and tell us about anxiety and depression, which are the most common mental health problems at the primary care level. And additionally, as also Dr. Roshni ma'am also highlighted that addiction also comes with this mental health domain. So for tobacco, we use a Fregastrom test for nicotine dependence that has two parts of smokers and non-smokers. And for alcohol, we can use CAGE questionnaire for screening and CYAR questionnaire for assessing the withdrawal symptoms in the patient. So these are some tools we can effectively implement even at the novice level, especially at the medical colleges. Even intern can be given with the supervised implementation of these tools. But one care should be taken because most of these tools are in English. So, and our patients will understand the local languages. So special care should be taken that what the tool really meant to ask, whether it is eliciting that or not. So validity and reliability should be taken care of. So we are exploring the community medicine specialist, we should take care of that. And at the medical officer level, they can readily use this tool with the effective guideline available with that. So with that, we can at least screen the patients. And for mild and moderate cases, there are already guidelines. There are certain courses like Diploma in Community Mental Health done by CIP Rachi and Enhance. So they can go through that course. I have also done that course. That's very informative course of 3 months only, engagement of 1 hour per week, Saturday. So they can do this course to enable themselves more in a better position to deliver effectively the mental health care to the primary care, the patient sitting at the primary care level. Thank you.
Thank you, sir. Thank you so much, sir. So I request the audience to kindly share the questions, if any, in chat box. We are taking the last round of questions for the panel discussion. So again, to going to Dr. Sanjeev, sir. Sir, what are the core competencies should a CFM graduate possess today in general, as well as to address the growing burden of mental health concerns in primary care?
Thank you for the question, Dr. Venkatesh. I'm assuming here I'm talking from the perspective of both the community medicine and family medicine. We all know that we have various medical education frameworks like the Bloom's taxonomy or the Miller's pyramid. So I was really surprised when I was going through the curriculums designed by, I will not say the name, designed by 3 or 4 the most popular curriculum designers of our country. When they have designed the curriculum, there is no structure in terms of lower order learning or higher order learning. So that was really surprising. And sometimes we jokingly say that this is post-lunch syndrome. So pre-lunch people are really much motivated while developing these curriculums. And post-lunch, some junior person or somebody has written it, and sometimes there are so many repetitions. So there is not much clarity. I will not say no clarity. There is clarity, but not much clarity. We also need to create some evidence in terms of whether the curriculum competencies which we have designed, they have really been effective. So primary care, dealing with patients, whether the patients are really being dealt in the primary care or people are missed out, like this Dr. Vijay right now pointed out, or the patients who have been really diagnosed and go mostly to the tertiary care. We often have discussion, right? Like we discussed with Dr. If I remember correctly, Dr. Roshni also. The doctors right now, what we see often that they want the patients to tell them the diagnosis. After that, they are the boss. So they know how to manage and everything. So that is not supposed to happen. The undifferentiated part and everything. So how to do that? Knowledge-wise, skill-wise, and the attitude part, the professionalism part. All three have to be combined. So a typical graduate should have epidemiological skills in terms of knowledge and skills, should be able to know the correct burden of these illnesses in his country, in his or her state, the district, the community also. So there might have been a lot of research done by the previous predecessors or some other colleges, and those are not compiled. I was really surprised when we were trying to the PG, one of the PG students, and I asked her to have a look at the knowledge gap. So this thesis database is the Shodh Ganga thing. So we did not have much. So it behoves on us also that we create a database at various levels. So what kind of evidence is available? So the doctor or the graduate should be able to know that, so that he or she can really think of or that the current patient or the next patient is going to be suffering from a common mental disorder, at least, or some serious mental disorder. That's the first part. So epidemiology, then the clinical skills. in community medicine, at least I will agree that we are really not that skilled. We are not practicing those skills. Probably we have never given enough emphasis on learning those skills, because even though we assess for them, we assess for very limited things. There will be a case of diabetes or hypertension under 5, that's it. So our postgraduates are not getting often exposed to common mental disorder during their assessment or during their PG activity or even UG activity. So the clinical, in terms of history taking, in terms of quick examination. Quick examination means how to do that examination in a busy OPD where you have only 2 minutes. That skill needs to be known. I remember Dr. Roshni correctly identified the clinical consultation skills. They are really outdated. I often talk to our students, MBBS students. You have been trained to do a clinical examination or the entire clinical history taking in 45 minutes. Who will give you that 45 minutes in an OPD? Never. So you do not know how to do that. Even if you are now, after becoming a medical officer or being a resident, patient is given enough time is there, but the student doesn't know what to do, because in real life he has not practiced. That mismatch is there. That clinical skill in a 2 or 5 minutes clinic, like we develop something. Uh, how to write those prescription. We have a framework when we have making diagnosis, writing the prescription and delivering that prescription. So in our country, what we do not have really trained pharmacists who can actually explain. So the prescription part, and more importantly, the non-pharmacological prescription part. That skill, which we just talked about that in the EdCom part. So that skill, how to deliver that prescription in terms of, say, for example, breaking bad news or doing counseling. We often see students saying, I will counsel the patient. Are you trained? Have you been through CBT? Do you even know what is MI? It's not myocardial infarction. This is motivational interviewing we are talking about, on the core skills in family medicine. So that then, do the student know how to estimate? So learning, simply reading, this much is the burden, creating this evidence. So can graduate really estimate the burden? Simple descriptive epidemiological study. Or can he or she really identify the risk factors in terms of by doing a simple analytical study like case control, by using the database, secondary data analysis, nothing special. So that skill should be known, how to do a simple, quick case control study, nested case control study, or a case cohort study. Those are very simple skills. If I remember, we have seen students who do MD, MPS combined courses in US. So they know these skills. They are graduates only. They are not postgraduates. And of course, we all know about the importance of advocacy. Somebody pointed out the skills of Dr. Santosh, how advocate he has. Dr. Raman, he is a great advocate. He has been able to probably very emphatically and successfully been able to implement MD family medicine program in AIIMS. Similarly, how a graduate should be able to advocate the importance of mental health or importance of uh, common medical disorders in his or her setting. That can be a PSC, that can be a private clinic, that can be a sub-center or Ayushman Arogya Mandir center. So that advocacy skills, we have so many skills, like somebody can use influence interest matrix, or maybe the stakeholder analysis matrix. These are simple skills which can be taught rather than doing some ritualistic work. How to really plan and do a health promotion activity. Simple thing like health policy analysis. So how health policies have been already been framed. So whether they are correct or not, whether they are sufficient or not. So that skill, Dr. Bhavesh Modi so beautifully demonstrated the importance of WHO building block. So that needs to be incorporated with real examples. Say, for example, the Mental Health Care Act or the National Mental Health Care Program, whether the program's objectives or the indicator, they really are in sync with those frameworks or not. So that can be taught to the students, and then this will help them when they are really having an opportunity to interact with a really senior person in policy. So I guess those kind of spanning from the epidemiological, clinical, interpersonal, system level, those kind of skills are required for the medical graduate.
Thank you, sir. Thank you, sir, for such a beautiful and elaborate answer. Thank you so much, sir. Next question to Dr. Roshni, ma'am. Ma'am, we have already touched upon few courses which are available for mental health and related things, ma'am. But as a as a young doctor, if we want to enhance our skills in family medicine, is there any formal pathways such as the MRCGP in which we can enroll and train ourselves?
Sure, yes. There is, I think, first and foremost, as we're discussing, that the community, you have to get in touch with a doctor who's practicing in the community, who understands the patient, and see how they are practicing, what are their consultation styles, how they are talking to the patient, how they are engaging with the family members and the patient in the room. So having a mentor or, having a role model in the community is of first importance. I mean, for young doctors to go and sit in the clinic and see what is happening to understand. Because when you're sitting in the clinic, right from the time when the patient walks in, to understanding the body language of the patient, to seeing what are the verbal cues. We say it's not every time that the patient is talking, there are some non-verbal cues. For example, if you see a patient, just rubbing his hands and looking here and there and not concentrating on you, you would understand that the patient is worried or concerned about that particular something. So you have to pick that up and you have to ask that, is there something worrying you? And that is where, the biopsychosocial model loops in. That is where patient also feels happy that the doctor is recognized and is able to open up to the doctor, and the hidden agenda is, unraveled. So I would say first and foremost, sit with a family physician who's practicing in the community. That's one. Second, coming to MRCGP, yes, we have training programs in MRCGP. Now, why MRCGP is, again, as I said, we have two parts of the exam. Now, in a country like India with such a huge population, we have seats in MD, we have in DNB, we have many other courses. But here, I think a lot of collaboration, a lot of inclusivity is also required so that we can train more and more family physicians faster. And so that, because the irony is, one is we have devalued MBBS and they're competing with quacks in the rural community. And at the same time, we are, not being inclusive and accepting the other courses which are there and taking them into faculty to enhance or making the system robust, because they are practicing in the community. Like, for example, I am practicing in the community, in an urban community, and through my trust, I reach out to the rural population where I do free clinics, I conduct camps. So I try to understand both the aspects. So regarding MRCGP, what it does is the basic knowledge test is in an applied form. So it's in AKT, which is applied knowledge test. You have 200 MCQ questions, which are clinical scenario based. You study for it, you apply it. The second part is the OSCE, which is very important, which is just nothing but a simple 10-minute consultation that you would do in your regular clinic, right from the word go, like when the patient walks in, and these are with simulated patients. Because we cannot have patients to be sitting, real patients to be sitting through 30 or 35 candidates every day and each taking up 10 minutes. So we simulate so that we can mark the candidates. So I think this is a very important course, and a course that will help you build up your skills. It's an aspirational course, definitely, at this stage, but it will definitely help you to do your community practice and understand the nitty-gritties of family medicine. Thank you.
Thank you, ma'am. Thank you so much for the answer. Next to Dr. Bijit, sir. Sir, can you please elaborate us on what are the practical strategies to build strong doctor-patient community relationships that support long-term mental resilience, especially in the low-resource or rural settings?
Thank you, Dr. Venkatesh. So actually, we are in the end of the panel discussion. I've been hearing the other panelists, Sanjeev sir and Roshni ma'am. So Sanjeev sir told how to certify skills. So and ma'am have highlighted about the MRCGP, the OSCE part, and the MCQ clinical vignet part. So we are at AIIMS also practicing the clinical vignet questions. Now our director have also ordered that all the questions should not be recall based. At least 25% of the questions should be clinical vignet based. So we have adopted to that. And we are also certifying the OSCE skills. It's a part of our exam. So OSCE skills, the sir told how to counsel, how to certify the his both are essential steps or not. So we have already implemented that. Regarding the internship training, so I have thought of implementing this year OSCE based evaluation. I will first teach them the skills that they require as a primary care physician, and then I will evaluate at the last based on the OSCE skills. So in this way, we can improve the medical training so that they can effectively community engaged, because community medicine part is always it was already there and already exists. But what lacking, previously what I heard, that the clinical part, the family medicine is an integral part of community medicine. So what was lacking now, the community medicine specialists become non-clinical. That's the main problem. We have to bring them back to that family medicine primary care domain so that they can effectively teach the students also in the primary care level. That's our responsibility. But suppose, for example, today my students came and that what hypertension, what guidelines we are following, they are saying some European guidelines we are following. But we are saying there are national guidelines as per JNC 8, so we follow that. So our role is to orient them what's the national, because after passing MBBS, they will be only able to serve as a medical officer or a medical practitioner, medical officer like that. So they should be oriented with the national guidelines. At the same time, they should be empathetic enough to the patient so that the patient open up. Regarding the question what you have asked me, that how to build the community resilience. So that's the basic what we inherently have as a community medicine specialist, how to interact with the patients and how to build rapport with the patients. Because we have to follow the principle. If you also follow the principles of the family medicine, like verbal cues, non-verbal cues, already ma'am told, that we follow the clarify, repeat, and the non-verbal cues, mind, open body posture. We follow those skills and golden 1 minute rule that we allow the patient to speak for a minute. And the 3-stage assessment, anyways, having the mental component like clinical, individual, contextual, with the individual aspect, we ask for the ideas, concern, and expectation of the patients. So if we follow the 3-stage consultation model, we can easily engage the community so that they open up. Because for mental health, as a community physician, I know there's plenty of stigma still exists. People don't want to accept that my child is having this problem, this hallucination, like what web series was Bhaveshwar was talking about. There, they was told about the mental illness only. The person, the ANM son, was suffering from mental illness, but ANM was not admitting that he is suffering from mental illness. And ultimately, the doctor got his first patient in terms of the ANM son. So, still, as a community physician, we should raise awareness about the mental illness, that it's a very common problem. Anybody can have. Like we are also running a school health program at AIIMS Patna, where we are introducing the model school health program. For mental health module, I started with this thing, कि आप लोगों से कितने लोग पागल हैं? I asked like this in the school. And they told, no, we are not pagal, we are not pagal. But if I say all of you are pagal, then how? Because we have certain site percentage. If it exceeds certain percentage, then we need counseling help. If it exceeds more percentage, then we might need medicinal help. So in this way, I try to inculcate the mental health concept in the students who will be our future patients in the community settings. And similarly, we have currently for capacity building, Government of India level, we are running telemanas where we can't reach, so they can seek the help for any mental health care illnesses. So by this, improving the clinical teaching, capacity building, creating awareness among the community, and also regarding especially the teleconsultation services and mental health illness, that they are not stigmatized. Anyone in any point of life might need help for any mental condition. So that might help for community resilience and might alleviate us to recognize this mental illness early so that we can intervene early and prevent them from going to the severe stage. And
Thank you so much, sir. Though there are a couple of questions in the chat box, we'll due to lack of time, we'll take only one question. And I would request Dr. Sanjeev sir to please take that question. That is, Dr. Akash has asked, sir, AIIMS has all specialty and subspecialty subjects. How are they integrating a family physician's OPD along with that?
Okay, thank you, Dr. Akash. We had an experience that OPD got closed 1.5 years back. So as we all have understood, we do not have a gated mechanism of healthcare delivery in our country. So anybody can walk in any AIIMS or at any tertiary, or even if we have a quaternary system. This is our fundamental right, or what we say. So there was a felt need that there would be a lot of patients who don't know where to go. And we are relying on the registration clerk. He or she will be sending the patient to different OPD. So that one OPD was running for a long time. And if I'm correct, many other AIIMS, like say for example, AIIMS Mangalagiri has a similar OPD, and I've been told that there is a 200-250 odd patients coming every day. AIIMS Rishikesh, they are doing it. I guess many other AIIMS are also doing it. Some AIIMS are not doing it. So there's always a space for this. There would be a lot of patients who are really undifferentiated in terms of they don't themselves know that where do they need to go. Since we do not have a graded mechanism, so a lot of patients would be coming without any referral to a specific departments. There would be a lot of patients who are really coming with minor illnesses or even chronic illnesses who are in lower levels, if we say like level 1 hypertension. So that those can be managed. So about 10 years that OPD ran in Bhopal. Similar OPDs are running in different teams also. So it can be done. It's not very difficult. And since the MD family medicine program has now been started at most of the AIIMS, a lot of the AIIMS, so now we can go forward with that. We are in consultation. We are in trying to develop a interest group of similar-minded faculty members from all the AIIMS. I have been in talks with many of them. So maybe we will develop some kind of model which we can advocate to the higher ups and maybe have a formal family medicine OPD that where AIIMS starts slowly. And hopefully we will have a structure, what kind of patient need to be there, what kind of patient need to be referred, and those kind of things. I hope I have answered your question.
Thank you, sir. Thank you so much. I once again thank all the panelists for such a fruitful discussion. So, since we are coming to the far end of today's webinar. To deliver the vote of thanks, I would like to invite Dr. Nilanjana Ghosh ma'am, Associate Professor of the Department of Community and Family Medicine in AIIMS Guwahati, and the organizing chairperson of this webinar. Over to you, ma'am.
Thank you so much. With this, we come to the end of the today's discussion, though it is just the beginning, I feel. And I'm very indebted at the outset. I'm very indebted and thankful to our executive director, sir, for giving us the scope and opportunity and always encouraging us with every new endeavor we think of. I'm extremely indebted to all our speakers who are our seniors, our teachers, our mentors. We have grown up literally listening to their videos. Pankaj Kumar sir, Bhavesh Modi sir, Raman sir, Santosh sir. So it's really like a learning for us also. I'm deeply thankful to all our panelists, Sanjeev sir, Roshni ma'am, Vijit sir, for your time. And least but not the least, Dr. Venkatesh, who is a rock solid support, the silent one. But this all thanks goes to him. So whenever we think of something, it is why I turn to, and every time he delivers it so beautifully. Thank you, Dr. Venkatesh, for all your time, despite you also having a very busy schedule. So after this, I will be thankful to ECO for helping us throughout. They are partnering institutions for telemedicine. To all our participants who have seen the program, and I will assure that we'll get the certificates after the session is over from end of ECO. So with this, we come to the end of this program, but we look forward to newer beginnings. Health is holistic, and we need to approach it from all the ends together. It is finally about treating a human being and getting him all right. So his health as a state of definition we all have learned. That is our final motto, and we all come together at one point to fulfill it. That is the idea. That was the idea of the program. Thank you so much.
Thank you so much, ma'am. Once again, thanks to all our expert faculties and enthusiastic audience for making this webinar a great success. We shall catch up with yet another engaging activity in the future. Thank you so much. We'll close
Let us
this.
all switch on our videos for once for the quick. So I request all the speakers, panelists, and moderators to switch on your video. The eco will have a pic. That's it. Is it done?
Yes, ma'am. But not all the speakers have switched on their videos. I think Dr. Santosh Kumar is not available. So can we skip, sir?
Yeah, we can have the then.
Okay, sure.
Rita ma'am, please join in.
Yes, ma'am, it's done.
So please share it in the group. And thank you so much. So with this, we come to the end of the session and I conclude the session.
Thank you so much, ma'am. This was a wonderful session. I think with this, we can conclude the session, and I request all the participants to just share their feedback. I have given the link in the chat box. I will wait for 1 or 2 minutes just to for your feedback, and then I'll conclude this session. Thank you. Thank you so much, ma'am. Thank you. Thank you, everyone.